Thanks, everyone. For this final session today, we have invited people to make public comments before the committee. We have had 4 people who have asked to make public comments. One of those is someone who is joining us here in the meeting room, and we have 3 people who are joining us remotely. I will call on those folks in order of their signing up and ask them to limit their remarks. We had asked for 5 minutes. We can flex that to 7 minutes today, but we would ask you not to go over that amount of time. If you would like to submit written information for the committee's consideration and for our public record, we would be happy to take that information. Copies of all information that is submitted to the committee are put in our public access file, where they may be read by anyone who makes that request. With that, I would like to invite our in-person speaker, Mr. Brown from Vietnam Veterans of America, to go to the podium and offer his remarks. Mr. Brown?
Hello, my name is Ronald Brown, and I'm a toxic wounds consultant with Vietnam Veterans of America. I'm also Operation Desert Shield, Desert Storm veteran who suffered respiratory illness from my deployment in the first Gulf War. There are tens of thousands of other Operation Desert Storm veterans who have also suffered respiratory issues from their deployment. Chairman Udall, distinguished committee members, thank you for the opportunity to address you today. It has been my hope that the information I've provided today will be beneficial as you complete the task before you. The literature review of respiratory health effects of airborne hazard exposure in Southwest Asia Theater of Military Operations. Research is very important. Veterans recognize this fact. Veterans also recognize research can never truly reflect the conditions and exposures faced during deployments. Again, I hope this information I am providing to you today will broaden your understanding of the conditions and exposures our veterans face. The Southwest Asia Theater operation is known for hazardous airborne exposures. Open-air burn pits have been used in theater since 1990. During Operation Desert Shield, Desert Storm, the burn pits were not as massive or used as extensively as they were in Operation Iraqi Freedom. Nonetheless, hazardous airborne exposures were just as great during Operation Desert Storm. In January and February of 1991, the retreating Iraqi military, as part of the scorched earth policy, set fire to a reported 605 to 732 oil wells. An unspecified number of oil lakes and fire trenches, resulting in the world's worst environmental disaster, according to Time magazine. It took nearly 8 months to extinguish the fires, April through November of 1991. During this time, veterans of Operation Desert Storm were exposed to high levels of benzene and other toxic chemicals. Due to time constraints, I will not have time to cover my entire presentation. I am providing each of you a copy. In it, you will find quotes from some of the veterans of Operation Desert Storm describing their respiratory illnesses while deployed and upon returning to their bases in the United States. These veterans have since suffered with respiratory illness that have impacted the quality of life and their earnings potential. They struggle to get the Department of Veteran Affairs to recognize the respiratory illness as service-related to airborne hazard exposures in Southwest Asia theater operations. I realize this committee has a charge to look at available research. I hope this committee will factor in the information provided in my presentation and consider it any conclusions you arrive at in your literature review. I thank each of you for the opportunity to present my presentation before this distinguished committee today. I look forward to answering any questions you have. Also, I encourage everyone who hasn't gotten a copy of it, it's back there on the table. I'd hate to see all those trees go to waste. So please help yourself to one of the presentations.
Do I have questions from members of the committee?
Thank you for that. Can you give me some insight into, you started off by saying research doesn't really fairly reflect what's happened. Maybe some insight into what are they missing, do you think?
Well, the monitoring during the Operation Desert Storm wasn't available like it is for the current conflicts of today. They basically went back and did most of the modeling on stuff, everything from the oil well after the exposure that we had. There was no baseline to start with before the deployment. And luckily, I'm hoping that the Department of Defense has started working to correct this on the current deployments of the U.S. service members. Thank you.
Mr. Brown, I was wondering if you could give the committee some insights on your own experience with respiratory health issues.
I didn't hear all your question. I'm sorry.
Could I ask you to give the committee some insights on your own problems with respiratory health issues?
Yes. Dr. Butler. Well, when I came back, I went through a study at Walter Reed. I did a CT scan. This is back in the 90s because I was having problems making run times after coming back. My run time went from like a 12-minute and anywhere from 12:54 to 12:30 time frame on my 2-mile run to over 18 minutes for my age. I was in my early 20s. Weighed 170 pounds. I was not obese. I was in some of the best physical shape I'd ever been in my life. I started falling out of road marches because I couldn't breathe. I didn't know how to explain it to my chain of command. I was scared to death I was going to be put out of the military on something other than honorable discharge. They were doing a reduction in the military at the time after the Gulf War where they would offer you an early out. I didn't know enough about the process of a medical discharge because I was a young enlisted soldier. So I took advantage of that and sought treatment on the outside of the military, which nobody could really explain to me. I've had 4 different diagnoses of my respiratory problems. It's been called everything from reactive airway disease, which is basically a catch-all diagnosis, asthma, bronchitis, to COPD. I use 3 different inhalers every day, this isn't about me. There's tens of thousands of me from the first Gulf War that are hoping that this committee can find something in this literature review to possibly make their life better.
Further questions? Thank you very much. Oh, I'm sorry. Dr. Spicer, please.
Yeah, can I sort of expand a little bit about that? With regard to sort of not wanting to leave the service, the sort of the person who thought they might have even had a long-term career, do you think that young people, 20s and 25, were hiding, not hiding, but sort of fighting with the fact that they were having symptoms for perhaps a long time? Was that common, do you think?
Yes, it was. People who generally went on sick call when I served, they were looked down on. It was an environment of you suck it up and you drive on. The mission always came first, and especially serving in a rapid deployment unit like I served in, physical fitness was very, very important. It's one of the top things, because no matter where you are, you could deploy it anywhere in the world in 18 hours at any environment. Operation Desert Storm was my second combat deployment. Deployed 6 months before that, basically, to Operation Just Cause in Panama. Didn't have any respiratory issues from that deployment. Was still making standards. Like I said, within about 15 minutes after the first demolitions happened at Camasia, which is included in the presentation, we were I started sweating profusely, difficulty breathing. I had blurred vision. Basically went to the field medic. They gave me an IV and gave me some ibuprofen, or as they call it, Ranger candy in the military, and said drive on. And you drank some water, take a knee, drive on. So came back to the States. We got a 4-day weekend. After that 4-day weekend was up, we had a PT test as soon as we came back, and I was not able to make the run because I could not breathe. I couldn't explain why when I was doing it, and I wasn't, like I said, wasn't obese. Probably, I don't know, 4 or 5% body fat. I was in great shape. I actually lost weight on my deployment while I was over there. So, like I said, there's tens of thousands of us who are struggling. It took me 13 years to get my respiratory condition service-connected through the VA. That may sound insignificant, but that's a long time. And I know this committee doesn't do benefits, but I know that your review will have an impact, hopefully, with the Department of Veterans Affairs towards those benefits. And we've got a lot of OIF veterans and brothers and sisters who've served, and they're impacted with respiratory illness just like our veterans 28 years ago and still are today. So this literature review is very important to them as well as it is to our Desert Storm veterans.
Thank you for your insights, Mr. Brown, and thank you for your service. I see that Mr. Hardy has his slides queued up, so if I could invite him to please begin his presentation.
We're trying here. Are you able to hear me? Hello?
Yeah.
No, we can. Yeah.
Thank you,
Okay.
Mr. Hardy. We can hear you.
Very good. Okay, and do you have are you able to see my slides, or am I going without them?
We can see your slides, sir.
Very good. Let's see. Okay, very good. I really appreciate this very committee for all of you serving, and thank you, Mr. Chairman, and staff and committee members for your willingness to serve as well. I'd like to talk just a little bit of a different angle. Ron, I really appreciate your presentation on the exposures, and I'm going to tag off of that as well. Veterans for Common Sense, you'll have copies of these slides later, but we're an organization that's been in existence since about 2003. One of our particular areas of focus is on toxic wounds, exposure, advocacy, toxic exposures. Many of our leaders have been involved in Gulf War veterans advocacy since the 1990s in the original national organization that formed at that time. This is my bio. I won't cover it in any depth except for just to mention that I myself am a Gulf War veteran and a veteran of Somalia afterwards. Did 7 years active duty military service in U.S. Army Special Operations. And I've been an advocate on Gulf War health issues for many years. including serving on a number of federal advisory committees. I currently chair the programmatic panel of the Gulf War Illness Research Program and chaired the external advisory boards that oversaw the Gulf War Illness Consortia at Boston and at Nova Southeastern. And it's great to see there today and here presenting Dr. Kim Sullivan and Dr. Nancy Klimas, who are the PIs of those two consortia. Many respiratory exposures, you've heard some about that, and you have the presentations that I do hope you'll pick up from Ron that help to highlight those. I've got personal experience as well, like Ron. Highlighted in yellow, which you can look at later if you happen to be interested, was a few paragraphs quoting my own experience in Joe Hickman's book, The Burn Pits. I developed respiratory issues while still in the Gulf and have called it my Kuwaiti cough at the time or after, immediately after, and that cough never ceased. Developed chronic sinusitis, had a couple of surgeries in VA shortly after service, and I've had a number of health issues since. So my respiratory issues, like Ron's, have been challenging to diagnose, and I've had multiple diagnoses as well. The current diagnosis is chronic bronchitis / COPD. I want to highlight today the impact of respiratory health research on veterans, and meaning particularly airborne hazards in Southwest Asia, that set of respiratory health research. First of all, it has an impact on healthcare. Americans generally expect that our war veterans are going to, when they come home, to provide a quality, timely healthcare following service by the military while they're still in service, and then by the VA. What most Americans don't realize, and perhaps some on the committee may not necessarily realize either, is that approval of getting the ability to secure that VA healthcare often rests on a veteran getting his or her claim approved by VA. There are other opportunities for getting healthcare for a period of time, but to ensure access and to ensure continued access, getting that claim approved is critical. Those claims and the approval of those claims are impacted by research. And the research, of course, also leads to evidence-based healthcare, as all of you well know and you've been hearing earlier. But you may not be as aware that what you do in this panel, in your work and your report, stands to have a significant impact on VA claims, which again are the gateway to VA healthcare for veterans. Diagnosed conditions, so conditions like you've been talking about, like chronic bronchitis, constrictive bronchiolitis, and so on, they require one of two things: either direct service connection, in which the veteran, in most cases, had some kind of has documentary evidence that they were treated for the condition while in military service. Whether or not it was recognized at the time as such, they have to have documentation they were treated for the condition in service. Or there's a presumptive determination made either through an act of Congress or through VA regulation. I'm really generalizing here for the sake of time, but in essence, these presumptive determinations lead to a blanket determination that either an exposure, like Agent Orange, or a health condition, like a particular kind of cancer or neurologic disease, is presumed, and those veterans are then able to get service connection. And again, that service connection leads, it's the gateway to VA healthcare. In the case of Gulf War veterans from 1991, there was a special category called undiagnosed illnesses, especially challenging since anyone that's a clinician here in the room, the tendency of our medical doctors is to diagnose. So getting these claims approved, while it was great by Congress, an act of Congress to create this presumptive pathway for getting claims approved, based on the symptoms that you see on the slide here, a number of symptoms, and I won't dwell on those, but chronic symptoms. Well, this has been the approval rate over time. Only a 7.9 approval rate over a 15-year period. Almost all of them have been denied. So that hasn't worked out well for Gulf War veterans. And unfortunately, under the undiagnosed illness provision, if there's a diagnosis of chronic sinusitis, of chronic bronchitis, of asthma, the moment that diagnosis is entered or is made, undiagnosed illness as a presumptive no longer applies. They now have to go through the other process of direct service connection, in which case there had to have been a diagnosis or at least evidence of treatment in military service, Military record keeping is an awful challenge for troops who are in combat. Gulf War veteran records from 1991 were lost across the board, and so that doesn't work out well at all for Gulf War veterans or other veterans, burn pit veterans, and so on, seeking their claims of approval, which again is the key to getting VA health care. One of the ways that VA has typically relied upon the national academies for reviewing peer-reviewed published research and making determinations of causation or association with regards to health conditions. In a number of volumes, 11 volumes plus a number of other volumes not in that set, the Gulf War and Health series, conducted and led by the National Academies and the Institute of Medicine as it existed previously. These are all of the determinations that have been made with regards to respiratory effects. In this column of a code, I assigned the code of A for causation, sufficient evidence of causation, B for the next stronger category of sufficient evidence of an association, the C category for limited or suggestive evidence, D for inadequate, and F for no association. As you can see, none of these rose to the level of the A or B categories of causation or sufficient evidence of association, in essence leading to no presumptives for Gulf War veterans for any respiratory health effects, including exposure to burning oil well fires, and of course then the challenges experienced by later veterans exposed to burn pits. The committee scope, you know this very well, so I'm just putting it up here on the screen very quickly, but I want to highlight two issues. The first in red, the next in green. You have the ability on your committee to harm the veterans by your work, as has been done or to not help at best veterans who are impacted by your work. In the past, as I showed a moment ago, there have been no categories of association sufficient to lead to new presumptions of exposure for VA to make those determinations. Again, without a presumption, Gulf War veterans have been left hanging and in trying to get their claims approved. Undiagnosed illness is an available mechanism, which is, you've seen what the results of that are. And for diagnosed conditions, that's next to impossible for Gulf War veterans in many cases as well. Again, leading to a denial of health care for these veterans. Your work here, the understanding of the potential adverse effects of in-theater military service on respiratory health, if you rely purely on connecting human studies of health impact, of the health impact and health outcomes related of respiratory effects in the Gulf War, this could do little to help veterans and potentially harm veterans. If you were to consider animal studies that connect various kinds of exposures known to be present in the Gulf Wars and health effects as a possible mechanism for why we're seeing respiratory health issues in people like Ron, like me, like perhaps others in the room, and like countless tens or even hundreds of thousands of other veterans, you could stand to benefit veterans. Highlighting now in green is that in your charge, you're allowed to make recommendations as you deem appropriate. And my last slide is to encourage you to do so. To consider the impact of your report, your conclusions, and your recommendations, and the impact that those will have on the evidence-based future diagnosis of respiratory symptoms. Also highlighting, I should have added here as well, but recognizing that some veterans' health issues are difficult to diagnose, and recognizing that there may be either epidemiological evidence or sufficient anecdotal evidence of an excess prevalence of symptoms that have been hard to diagnose. Anything you're able to write in your report and can make conclusions in those areas would be helpful to veterans. Second, I guess I covered the second point as well. And then third, keeping in mind that what you do in this committee will have an impact on VA's determinations on presumptions of exposure. And finally, all of that has an impact on veterans' claims, which again is the gateway to these veterans like Ron and like me and like so many others being able to get access to VA health care. thank you for your time. I'm happy to answer any of your questions.
Thank you, Mr. Hardy. Do we have questions from the committee? I'll start out with one. Mr. Hardy, do you believe there are any particular respiratory health outcomes or exposures in theater that the committee should be giving special attention to?
I do. So first of all, with regards to burn pits, we've heard an awful lot of in the press and in the veterans communities about constrictive bronchiolitis. We've heard some today about the challenges in diagnosing constrictive bronchiolitis. There may be other issues that don't perhaps result in the specific diagnosis of constrictive bronchiolitis that I think are important. Those are with regards to exposure to burn pits and perhaps also exposure to chemical warfare agents in both the Operation Iraqi Freedom and Successor operations and also in the Gulf War. So I want to highlight as well not just health outcomes, but exposures. Not just chemical warfare agents like sarin, cyclosarin, and cyclosarin, but also the mustard gas and lewisite. If you were to read my portion there, I have long believed that that was what I was exposed to going through an Iraqi bunker complex in 1991 due to the characteristic odors and my immediate health effects, my soon after health effects that began, I shouldn't say immediate, but my soon after health effects that began within 24 hours. So exposures. And then finally, the third is I see in your project scope, I was pleased to see the addition of sinusitis. And early on, after the Gulf War, in my early years of advocacy in the 1990s, I asked county veteran service officers and others working on claims if they saw anything unusual in Gulf War veteran claims as opposed to previous generations of veterans, Vietnam and others. And they noted two sets of conditions: gastroesophageal reflux disease, which can, of course, have an impact on respiratory health as well. I'm a person who've experienced that and have had the NASEM fundoplication surgery. And then second, chronic sinusitis was the one that they said across the board they saw regularly. People like Ron and myself have dealt with chronic sinusitis, have had surgeries for it, many others as well. And so those are sets of conditions, but also exposures that I hope you will consider all of this. And thank you for asking that excellent question.
Please go ahead, Sverre.
Yeah, thank you, Mr. Hardy. I wanted to get clear on what you were talking about with respect to the poor acceptance rate of service connectedness for known conditions, either nude conditions or aggravation of conditions. And you made the point that documentation was really poor. So is it your feeling that it's really poor documentation that's at the root of the low acceptance rate, or is there something else?
We've advocates have identified a number of reasons for denial. There are two different sets of claims, types of Gulf War claims in particular we've been working on, and I covered the undiagnosed illness claim because that's most relevant to what we're talking to today. There are also some presumptives for some chronic multi-symptom illnesses like fibromyalgia, chronic fatigue syndrome, and irritable bowel syndrome. There's been across-the-board denial in those areas, chronic multi-symptom illnesses as well, about an 80% denial rate. That's lower than the denial rate of greater than 90% for undiagnosed illnesses. But what this means is there's no current clear pathway to service connection for veterans with a respiratory health condition. If they have a diagnosis, even a symptoms-based diagnosis like chronic sinusitis, they're not eligible for filing a claim under undiagnosed illness, and it's extraordinarily difficult to file a claim as a chronic multi-symptom illness for those symptoms. So there are. You asked about documentation. Medical records were across the board lost for 91 Gulf War veterans. This is particularly important in the case of veterans who were served in the Gulf who were reserve and guard members whose only their active duty ended almost immediately upon redeploying from home to the U.S. from the Gulf. For veterans who were on active duty, like myself, we had further opportunity to seek health care if we were in for a few months or a few years or many years after our Gulf War service. But there were real challenges in doing so, and so some of us, like myself in particular, waited until leaving service to do much with trying to access health care. So where I'm going with all of that is that veterans may not have had the ability to get a diagnosis of these health conditions. They may only know that they have a chronic cough and continual lung infections and sinus infections. They may not have a diagnosis. If they don't have access to VA health care, it can be very difficult to get a diagnosis. We've been hearing some about constrictive bronchiolitis and the challenges of getting a diagnosis for that. And so your recommendations will be critical in terms of, with regard to symptoms, not just diagnosed conditions as well. And I hope that helps to clarify, and please feel free to ask a follow-on question if I was not clear.
No, thank you.
Mr. Hardy?
Yes.
Okay. It appears as if we've completed questions from those on the committee. Thank you again for your input and for your service. We understand that Mr. Swift is having some technical difficulties in connecting to us, and if Ms. Nichols is monitoring the broadcast, we hope that she will get in contact with us quickly. We'll try to get that resolved over the next couple of minutes. If we're not able to do that, I would invite Ms. Nichols, Mr. Swift, to submit comments in writing, and anyone else who is listening to this broadcast, if they wish to submit materials for the consideration of the committee, we would ask that they get in contact with us. The email address for that is Gulf Resp Health, and I'll spell that out, GulfRespHealth, Gulf Resp Health, at NAS for National Academy of Sciences .edu. We would be happy to take submissions now or at any time while the committee is operating for consideration. As I mentioned before, any submissions that we get will be circulated to the committee, and a copy will be placed in our public access record. Unfortunately, it doesn't appear as if we've been able to make contact with Mr. Swift or Ms. Nichols to get them online. So with that, I'll touch base with Dr. Utel for any final comments for today.
Just want to thank again all of the speakers for being so well prepared and excellent presentations. Speaking for the committee, we've found the dialogue very, very interesting, and we'll certainly utilize the information that's been presented. To those of you in the audience or online or on the phone, again, thank you as well. We will reconvene tomorrow. The open session begins when 9 o'clock in the morning. The focus will be on in-theater exposure assessment, and all are welcome to join us. And we look forward to another interesting set of presentations tomorrow morning. So with that, I think we'll sign off and see you tomorrow.